Good evening and welcome to the Dean's Seminar in Integrative Healthcare. This is Saybrook University's effort to feature the work of recent graduates. We welcome students and rather alumni who have graduated from either college, although this evening our speakers come from graduated from the College of Integrative Medicine and Health Sciences, and particularly the Department of Mind-Body Medicine. Our first presenter will be Dr. Casey Applegate-Aguilar, who holds the doctorate in Mind-Body Medicine with a specialization in Integrative Mental Health and a certificate in Clinical and Applied Hypnosis. Her pre-doctoral educational background was in psychology. She earned a BA at Lamar University, a master's at New Mexico Highlands University, also a background in English with a BA from Lamar University and a master's from New Mexico Highlands, and also education, a post-baccalaureate certificate in elementary, secondary, and special education from Santa Fe Community College. Her experience includes teaching, both K-12 teaching and also university teaching. She's been involved in student success initiatives, opioid recovery, community mental health, inpatient psych, and school-based health. She's currently in private practice in New Mexico, the land of enchantment, specializing in trauma, parenting, and wellness-first education. So welcome, Casey, and I look forward to your presentation.
Thank you, Dr. Moss. The title of my dissertation was Implementation of Mindfulness-Oriented Recovery Enhancement in Medication-Assisted Treatment for Opioid Use Disorder, a qualitative classical Delphi study. My wonderful committee consisted of Dr. Vega, Dr. Heitner, and Dr. Jameson. First, a bit about the broader background of my topic. Increases in opioid-related deaths have spurred national initiatives for prevention and recovery. Prevention is highly focused on non-pharmacological treatments now for pain, while recovery is highly focused on pharmacological treatment of opioid use disorder, or OUD. Methadone, buprenorphine, and naltrexone are prescribed as pharmacotherapy for OUD. Medication-assisted treatment, or MAT, is pharmacotherapy in combination with behavioral health services for substance use disorder, or SUDs. The National Center for Complementary and Integrative Health noted the potential of mind-body therapies for pain, including cognitive behavioral therapy, or CBT, neurofeedback, hypnosis, and mindfulness meditation. Additionally, the NCCIH noted that chronic pain, or as I'll refer to as CP, is highly comorbid with OUD, and there is a need for mind-body therapies in MAT treatment. Now a bit about mindfulness-oriented recovery enhancement, better known as MORE. Building upon the available research on the psychoneurology of substance use disorders, Dr. Garland and colleagues conceptualized substance use disorder as a dynamic, self-perpetuating neurobiological and socio-cognitive system in which stress precipitates and maintains neurobiological allostatic dysregulation, automatic cognitive processing, negative emotions, and addictive behavior. Garland developed MORE to address this system. There are three components of MORE: mindfulness, brought in from Buddhism, Zen, savoring from positive psychology, and cognitive reappraisal of meaning, brought in from CBT. Now I'd like to offer a more specific background of the problem I addressed in my study. In 11 randomized controlled trials, researchers have substantiated MORE as efficacious for populations with CP, OUD, or co-occurrence of these conditions. Quasi-experimental effectiveness research on other mindfulness-based modalities in MAT indicates a likelihood that MORE would also be effective in authentic MAT settings. Qualitative research on other SUD treatment modalities indicate the importance of identifying barriers and facilitators to implementation. Despite the demonstrated efficacy of MORE and its likely effectiveness in clinical practice, only about 700 clinicians internationally have trained to provide this modality as of 2023. The extent to which these clinicians have successfully implemented MORE in clinical practice, or in MAT specifically, is unknown. The problem is the research to practice gap, which is the time and activity involved in moving an evidence-based intervention in EBI from research into everyday clinical practice. Establishing an innovation as efficacious and effective doesn't guarantee practitioners will implement it. Clinicians may find the practice undesirable or difficult to implement outside the research context. Perceived feasibility by clinicians is critical to initial adoption and further implementation. Clinician input is essential to understanding the feasibility of widespread implementation of EBIs. The purpose of my study was to determine how a panel of MAT experts viewed the desirability, feasibility, and importance of forward-looking strategies for bridging the research to practice gap for more in MAT in the United States. The research question was an inversion of that, and I created sub-questions focused on desirability, feasibility, and importance. The research on this topic is vast and transdisciplinary. I addressed the literature in a way that gave a broad overview, but focused on the most current and relevant research. First, I'd like to offer a bit about the development of my interest in the topic, how it informed my approach to the literature review. My initial interest in this topic developed from my work in a MAT program in rural New Mexico. Given the trauma, ongoing stress, and physical pain I assessed in the clinic's MAT population, I wanted to introduce clients to mind-body techniques they could use to reduce emotional reactivity and physical discomfort that seemed to lead to recurrence of use and reduce quality of life. As a behavioral health therapist, I followed a stress management and relaxation group manual adapted by Detmer in 2006 for trauma treatment at the VA clinic in Albuquerque. This manual integrated several mind-body practices such as hypnotic techniques, progressive muscle relaxation, guided imagery, and mindfulness alongside CBT. The changes I noticed in my clients as I introduced these techniques piqued my research interest. My original searches of the literature focused on imaginative techniques for co-occurring OUD and chronic pain, particularly hypnosis. Due to the limited research on hypnosis for these co-occurring conditions, I expanded my search to related mind-body therapies. It wasn't until I was looking into art therapy and neuroaesthetics that I came across a theoretical article on Moore. I didn't realize at the time that there was an entire body of literature on Moore, or that it was a manualized modality. After continued research on mind-body therapies, I found additional studies on Moore, and the publications continued to be published as I researched. The research on Moore appeared to be the most recent, robust, and relevant to my focus. I then conducted a literature review on Moore, which revealed the gap as a lack of research on real-world implementation of Moore, including possible barriers and facilitators to implementation. I became curious as a clinician about why I didn't know about this modality sooner, which led to researching the literature on research to practice gaps and implementation science. Research to practice gaps continue to affect quality care and outcomes for OUD. The National Institute of Health and National Institute on Drug Abuse continue to address the gaps to contend with the opioid crisis. Their strategic plans are focused on developing EBIs, understanding research, studying implementation of EBIs, and supporting translation of EBIs into practice. The NIDA-funded Cherish Conference policy recommendations were for insurances to cover alternative modalities for pain management and for the support of hub and spoke models. There are two types of hub and spoke models. One is the Vermont model, which is focused on the treatment gap or getting patients to treatment. And the other is the University of New Mexico Project ECHO, which is focused on clinician training and a community of practice to support implementation of modalities. The conceptual framework of my study is implementation science, the scientific study of methods to promote the transfer of research into routine practice and thereby improve quality care and health service effectiveness. Implementation science is concerned with technology transfer, the multidimensional process of technology development, dissemination, and early implementation. Simpson's framework for transferring research to practice involves 4 stages of technology transfer: exposure, which is training; adoption, which is the decision to try it; implementation, which is exploratory use; and practice, which is maintained use. My literature review covered research relevant to the issue of chronic pain in OUD, mind-body therapies for chronic pain, including Moore, and mind-body therapies for substance use disorders, including Moore. Most relevant to my research is the literature on mind-body therapies for co-occurring OUD and CP. there is less published research on the co-occurring conditions. Garland and colleagues have supported the efficacy of more for the treatment of chronic pain and co-occurring opioid misuse in primary care, and the superiority of more over CBT in the treatment of these co-occurring conditions. Most relevantly, Garland and colleagues demonstrated the efficacy of more for methadone MAT under randomized controlled conditions. Research has used quasi-experimental designs to test effectiveness of mindfulness-based interventions, MBIs, in MAT with promising results. The results of studies conducted by Malik and colleagues and Zolig and colleagues suggested that other MBIs, such as MORE, that have demonstrated efficacy in our randomized controlled trials would also demonstrate effectiveness in authentic MAT settings. However, even if a modality is efficacious in controlled trials and effective in quasi-experimental research, practitioners may find it difficult to move into practice. Qualitative research on other substance use disorder modalities suggested that unique barriers and facilitators likely exist for more implementation as well. This qualitative classical Delphi study involved the collection of open-ended Likert-type response scale and rank order data from expert panelists over 3 iterative rounds to determine experts' intuitive insights and informed judgments about the research questions. A Delphi design was appropriate for the study because of the limited literature on the applications of implementation science to more and MAT, and the potential for variant opinions and possibilities about bridging the research to practice gap in this context. I chose the classical Delphi rather than a modified because I needed panelists first to identify the possible strategies. I used purposive sampling based on a priori selection criteria combined with snowball sampling, and I aimed for approximately 25 participants in round 1 to account for expected attrition between rounds. The goal was to have at least 5 panelists in round 3. However, difficulty obtaining a panelist in round 1 resulted in extended time between rounds 1 and 2, and concern that the longer wait time would increase attrition. But I ended up extended round 3 to 3 months and ended with 16 panelists for round 1 and 10 for round 3. Participants were MAT experts defined as having reported experience working in MAT as medical clinician, behavioral health clinician, nurse, or peer support specialist for at least 2 years in the U.S., as well as willingness and capacity to participate. Professional networks facilitated recruitment. I recruited via direct invitations and postings on social media and email. The study announcement was also shared to the New Mexico State Opioid Response and Opioid-Related Project ECHO listservs. Following informed consent, panelists completed an eligibility screener. Next, panelists completed a demographic survey. After that, they moved on to the introductory material and then the round 1 questionnaire. The study was comprised of 2 iterative survey rounds that varied in length and format, round 2, and round 3. And now I'll share with you the results of this study. 16 panelists completed the round 1 questionnaire. Of these panelists, 9 identified as female, 7 as male. Panelists ranged in age from 34 to 66 and over. 2 panelists reported highest degree earned as bachelor's degree, while 7 reported master's and 7 reported doctoral degree. 12 reported currently working in outpatient MAT. The majority of panelists reported having worked in MAT for OUD between 2 and 10 years. An equal number, 7, of panelists reported MAT role as behavioral health clinician, the other 7 as medical clinician or prescriber. 2 panelists reported a peer support specialist role. Panelists responded to questions about the integrative and collaborative nature of the MAT programs in which they currently or most recently worked. Over half of panelists reported that the MAT programs they worked in integrated complementary and conventional practices. Likewise, the same percentage of panelists reported that the MAT programs they worked in integrated non-pharmacological pain management. The majority of panelists reported a collaborative MAT environment. Meanwhile, 6 reported a very collaborative environment and 1 reported a somewhat collaborative environment. Panelists also responded to questions about their familiarity with mindfulness and more. 7 panelists reporting being very familiar with mindfulness and another 7 being familiar. 2 reported being somewhat familiar. Overall, panelists were less familiar with more than with mindfulness in general. 3 panelists reported being very familiar with more, 4 being familiar, and 4 being somewhat familiar. Meanwhile, 3 reported being unfamiliar and 2 being very unfamiliar with more. To account for expected range of panelists' familiarity with mindfulness and more, as well as the diversity of panelists' backgrounds, I provided them introductory information to review proceeding to the round 1 open-ended questions. This introductory information allowed panelists to enter the questionnaire with a shared understanding of the topic and key concepts of the study. While I recruited panelists nationwide, participating round 1 panelists represented MAT employment in only 10 U.S. states, with a quarter representing Arkansas. 40 potential panelists entered the survey, but only 16 of them completed the open-ended questionnaire. 12 of the 16 panelists who completed round 1 also completed round 2. Of those 12 panelists, 10 completed round 3. Based on the individuals who completed round 1, the overall panelist attrition rate was 37.5% across 3 rounds. 25% of this attrition rate occurred between rounds 1 and 2. In round 1, 16 panelists provided narrative answers to 6 open-ended questions about implementing more in MAT. I used iterative thematic analysis to analyze the narrative data. 79 forward-looking strategies categorized within 9 barrier themes emerged from the round 1 narrative data. These 9 themes and 79 strategies comprised the round 2 survey. The 9 barrier themes were professionals' exposure to and increased buy-in for more, professionals' resistance to change, professionals' training needs for more, quality of more training, patient education about and buy-in for more, institutional resource readiness for more, collaboration for more implementation, project management for more implementation, and delivery of more. In round 2, panelists rated the 79 strategies for desirability and feasibility on Likert type response scales. I performed frequency and media analyses and determined that 41 strategies met consensus criteria to advance to round 3. You can see here that strategies for theme 6, which was strategies to support institutional readiness for more, were all eliminated due to feasibility issues in round 2. In round 3, panelists first selected the 5 strategies they believed were most important for implementing more in MAT from the 41 forward-looking strategies advanced from round 2. Overall, the panel selected 20 of the 41 strategies as most important. Next, panelists ranked their selected 5 strategies in order of importance. I determined border scores indicating the importance level of the 20 selected strategies, and selected the top 5 highest scores as the most important strategies according to the study panelists. Those strategies were include more in licensed counselor education curricula, provide education on the importance of more at professional organizations such as the American Association for the Treatment of Opioid Dependence and the American Society of Addiction Medicine, where CE credit is earned, emphasize that more is an evidence-based intervention, increase accessibility for more training by providing greater opportunities for training through professional organization continuing education programs, and provide training on ways to integrate more with current treatment modalities that have been the gold standard in substance use treatment, e.g. CBT and motivational interviewing. Now for a bit of discussion in the context of implementation science. According to Simpson's framework for transferring research to practice, a better understanding of the process of program change and potential barriers is necessary. Using Simpson's framework, researchers found that barriers and facilitators of implementation vary by EBI. As I mentioned earlier, Berger and colleagues and Amadeo and colleagues identified barriers and facilitators to motivational interviewing, ACRA, assertive community treatment, and CBT. The findings of my research aligned with this prior research. In my study, the primary barrier things for more were professionals' exposure to and buy-in for more, which relate to training and philosophy, professionals' resistance to change, which could be related to philosophy, access to training, and the quality of more training. Other barriers were related to time, resources, and client participation. Analyses revealed alignment with Amadeo and colleagues' facilitator categories as well. particularly related to training and professional buy-in or openness to new modalities. Simpson's implementation science framework provided a lens for exploring my study's data. My study aligned with Simpson's framework in terms of training and implementation. However, the focus on dissemination fell outside of the scope of this framework. The 5 top-ranked strategies in my study all focused on dissemination or training. In context of Simpson's framework, the patterns within the reduction of strategies in rounds 2 and 3 may indicate that additional work is needed to advance more into adoption and implementation in MAP programs. In round 2, strategies in themes 3, 6, 7, 8, and 9 were most greatly reduced due to not meeting criteria for consensus. These 5 themes primarily focused on MAP program implementation, accessing training, primarily strategies involving MAP program organizational efforts, institutional readiness, resource readiness, collaboration for implementation, project management, and delivery of more. The early reduction of strategies and barrier themes related to Simpson's implementation stage may indicate that panelists felt that more implementation is not currently highly feasible, as few strategies were reduced due to desirability concerns. Strategies focused on implementation might seem more feasible once more is widely disseminated and a greater number of clinicians have trained in the modality. Theme 6, which is supporting institutional resource readiness for more, was the only theme eliminated in round 2. These funding-related strategies were rated high for desirability, yet low for feasibility, and therefore did not meet consensus. This finding appears to indicate that while resources are necessary to implement more, panelists did not believe such resources were easily attainable. The literature supports this view, indicating funding as a major challenge to EBP implementation, and noting a lack of research on financing strategies that support EBP adoption, implementation, and sustainability. Panelists' comments indicated that increased buy-in could positively affect funding, highlighting the importance of addressing dissemination and exposure as a first step to moving research into practice, while also highlighting the dynamic nature of Simpson's framework. Now I'll discuss the 5 strategies ranked highest in round 3. The top 2 strategies focused on 2 channels of dissemination: graduate school and continuing education. Strategy 1.8 highlights the importance of beginning exposure to new modalities in graduate school. An aspect of consideration for this strategy is its focus on behavioral health clinicians, which may indicate that panelists perceive training behavioral health clinicians as more important than training medical clinicians and more. Medical clinician panelists' round 1 responses often focused on increasing their access to behavioral health clinicians trained in more. These comments suggest that MAP programs may not have the integrative support necessary for implementing more, despite the definition of MAP as integrative and the federal requirement for MAP programs to provide counseling alongside medical care and other psychosocial services. While Strategy 1.8 focused on graduate school training, Strategy 1.1 focused on continuing education. Interestingly, similar to strategies that focused on providing education on the benefits, foundational premises, efficacy, and implementation success of more at professional organizations did not rank in the top 5 strategies in round 3. While these strategies are all related, emphasizing importance may be a first step in creating interest by suggesting a need. Simpson explained that the exposure stage is mediated by readiness or motivation for change, which is the perceived need and pressure for change. The findings of the current study suggest that dissemination may function as a way of creating a sense of need, which could lead to seeking training. Simpson and Flynn described how professionals may decide to attend a training offered in a conference-based setting by first weighing how relevant the training is to their needs. Highlighting the importance of more could position this modality as a solution to unmet needs by both bringing the need to the surface of awareness and suggesting more as relevant to meeting that need. In tandem, strategies 1.8 and 1.1 highlight the importance of increasing dissemination of more through inclusion in training programs that already exist. Strategy 2.6 tied for the 3rd highest border score. This strategy focused on addressing professionals' resistance to change by emphasizing that more is an evidence-based intervention. The evidence-based movement, which originated in the field of medicine nearly 40 years ago, has transformed both medical and mental health fields, affecting research, practice, policy, and payer reimbursement. The use of modalities supported by efficacy studies is a critical aspect of service delivery in substance use treatment programs, according to the Institute of Medicine. However, as Kazin and Pagotto and colleagues described, confusion exists regarding how evidence is used in mental health fields due to a misconception that evidence-based practice, EBP, refers to using standardized, empirically supported interventions, EBIs, in lieu of clinical judgment. While an EBI is a specific protocol found to be effective in controlled research studies, EBP is a process of making clinical decisions based on evidence, clinical judgment, and patient needs and values. Pagotto and colleagues suggested that increased dissemination of the principles of EBP might facilitate the adoption of innovative, evidence-based modalities. In a study conducted at the beginning of the evidence-based movement in mental health, Pagotto and colleagues found that behavioral science professionals perceived the greatest barrier to EBP was negative attitudes about empirically supported treatments. They found that these negative attitudes reflected a misconception that EBP meant blind use of empirically supported interventions. In contrast, my study results indicated that professionals now view EBIs as desirable and important for persuading clinicians to consider use. Panelists' narrative responses indicated that the current desire for EBIs may originate from resistance toward new modalities due to previously established gold standards in treatment settings, i.e. CBT. Strategy 2.6 may indicate a larger issue in the field related to a lack of clarity around EBI and EBP. This confusion may stem from the complicated relationship between research evidence, clinical guidelines, and payer reimbursement guidelines. Strategy 3.4 tied for the third highest board score. This strategy aligned closely with strategy 1.1, the second ranking strategy. The difference between 1.1 and 3.4 is a slant of focus. While 1.1 focused on providing education on the importance of more at professional organizations to increase dissemination, 3.4 focused on increasing accessibility to more by providing greater opportunities for training at professional organizations. The ranking of strategy 3.4 highlights the importance of ongoing accessibility to training, which could support implementation and continued use rather than only spark an interest. Strategy 3.4 supports Simpson and Flynn's description of how professionals may decide to attend training based on its accessibility and whether it provides continuing education credits. Strategies within Theme 4 supported and extended the research on identified key elements of training, such as experiential learning, clear manuals, and collaboration. Strategy 4.9 ranked as the fifth highest board score. This pedagogically focused strategy suggested that providing training on ways to integrate more with current treatment modalities that have been the gold standard in substance use treatment, such as CBT and MI, would improve more training. Narrative responses, which developed into strategies in round 1, indicated that study panelists perceived the field's emphasis on CBT as both a barrier and a possible facilitator to implementing more. For example, strategy 2.7 highlighted that placing emphasis on how more incorporates CBT could help address professionals' resistance to change. However, this strategy did not rank in the top 5 scores, perhaps because of its focus on how more already includes CBT, rather than how to integrate more with current CBT used in practice or other modality practices. In contrast, strategy 4.9 focused on the practicality of learning how to integrate more with popular modalities such as CBT. This focus on integration with current practice highlights an important panelist perception about implementing a new modality. Training must not only address how to use the new modality, but also how to integrate it. Providing such training might address the professional's resistance to change by increasing the perception that implementation is feasible. My study findings support Simpson and Flynn's considerations regarding training quality. They emphasize that training quality influences professionals' decisions about the modality's value and their perception of preparedness for implementation. Strategy 4.9 suggests that training should address integration with professionals' current modalities to improve confidence in implementation and a perception of feasibility. This type of training may require individualized coaching and practice because professionals' current treatment modalities will likely differ. While therapy manuals may support fidelity, practice and coaching are critical for effective implementation, perhaps in part because of the flexibility needed to integrate modalities in clinical contexts. In a meta-analysis of MBIs, including more, Sancho and colleagues found that MBIs appear most effective when integrated with other active treatments for substance and behavioral addictions. While researchers might view the integration of modalities as a fidelity issue, a meta-analysis suggested that adherence and competence in a modality are not related to patient outcomes. Rather, flexibility and creativity are necessary to make modality implementation feasible and effective in clinical practice. Trainers can support adoption and implementation by teaching key principles of a modality that clinicians can use flexibly to meet the unique needs of their environment and clients. Several limitations may have affected the trustworthiness and outcomes of this study, including panelist biases, self-selection, lack of motivation, misunderstanding. While anonymity among panelists may have encouraged free expression of opinions and reduced social desirability bias, it may also have reduced accountability and resulted in impromptu responses. Additionally, anonymity between panelists disallowed debate, yet live debate could have clarified responses and changed the outcomes of the study. For Delphi studies, the time frame between rounds is a known factor in attrition rates, and attrition can affect the depth of data collection and panelist motivation best effort. The small sample size and attrition rate across the 3 rounds may have affected the results of the study. Panelists who did not participate in all 3 rounds may have had different views. Researcher bias also limits the study. Biases involved in developing the questionnaires and analyzing data may have affected the results. While I used a field test, reviews by my dissertation committee, and reflexivity to address personal bias, it is probable that biases affected the development of the research tools and the interpretation of data, which is expected in qualitative research. The outcomes of this study represent the opinions of a limited number of self-identified experts during a particular time. Transferability is limited by readers' determination of the applicability of the study, results to their context. A Delphi study is designed to identify areas of future research and practice considerations rather than to determine a definitive answer for generalization. Qualitative Delphi research is meant to prompt ideas for future research. I have so many ideas for future research, but not enough time to tell you about all of them here. If you're looking for research ideas, I've explored many in my dissertation. Give that section a read. Through experimental designs, researchers can investigate effectiveness of more. Mixed methods are also a possibility. Action research is also a possibility. Implementation science research is considered the new frontier, and this project indicated considerations for next steps in implementation science research for more by distilling expert opinion about the desirability, feasibility, and importance of forward-looking strategies. This Delphi forecast for more in MET may assist in expediting the bridge from research to practice. The findings indicated where researcher and practitioner time and energy are most needed in dissemination and training efforts. The outcomes of this study highlighted considerations for dissemination and training, implementation, perhaps later on. I do go into detail in my dissertation about how themes 5 through 9 might be used to support implementation efforts and avenues for future research. More broadly, the research may support improvements to MAT programming by highlighting important considerations for implementing research-based mindfulness practices, which may support improvements to MAT programming. Thank you.